Good morning, everybody. So as you know, today we're talking about pain management in the elderly. So here are the objectives for today. Going to look at the demographics of the elderly, talk about various barriers to effective pain management, understand some pharmacokinetic differences in the elderly, and discuss a few pain conditions and appropriate, or I should say inappropriate, analgesia. So this slide is showing the demographics, and in 1900, there were 3 million adults over the age of 65, the blue line. And that number in 2000 rose to 35 million, and in 2008 to 39 million, which is about 13% of the population. And as the slide shows, in 2030, there will be an estimated 72 million people over the age of 65, which is really quite enormous. And that will be about 20% of the population. The green line represents those often called the oldest old, which are those 85 and older. And in 1900, there are 100,000 of those people. In 2008, there were 5.7 million. And projected in 2050, there will be 19 million. So these numbers are really quite impressive. And you really can't avoid the elderly when you're doing adult medicine. In 2009, about 1 in 8 Americans were over the age of 65. And this year, the baby boomers started turning 65. So what's so unique about the elderly? Well, one is that they're often not included in clinical trials. So very often we have to extrapolate data, which may or may not be the right thing to do, but it's what we have to work with. But as the baby boomers are, increasing in number and the elderly population is increasing, clinical trials will be forced to include more older people. When they do include older people, very often they're healthier older people, which also doesn't really help us in our work. They live in communities, SNFs, which are skilled nursing facilities, and ALFs, which are assisted living facilities. And that's also something unique. In the communities, they can live in general community, they can be your next door neighbor. They can also live in communities called NORCs, which are naturally occurring retirement communities. Their perception of pain may be different. There's some debate about that. And the reason for that is really not well known. There's a great variability in the elderly. If you think about it, you may have an 85-year-old who's living independently on very few medications, really taking care of their lives. And we may not even run into them. And on the other hand, there may be a 66-year-old who's in a nursing home who is pig-fed and really quite out of it, having had multiple strokes, multiple chronic medical conditions. And then what about the caregivers? Adult medicine, we tend to just deal with the adult themselves. But with the elderly, especially as they get older and depending on where they live, we may be dealing with a caregiver. And very often the caregiver may be children, and the children themselves may be elderly. So we're going to look at barriers to effective pain management. Patient and caregiver factors, physician factors, and then other factors and other practitioners. So what are some of the patient and caregiver factors? So, of course, fear of addiction. Definitely have heard of that. Sometimes you'll hear them say they've heard of someone who, had a bad reaction to, Percocet or a bad reaction to something else, and, therefore they're not taking it. They're not going to try it. They want nothing to do with it. Some cost concerns. Some medications can be, quite pricey, and depending on the insurance that they have, if they have insurance at all. They may have Medicare or drug insurance, and then you have to deal with the gap, the donut gap. Side effects of medications. And then denial, of course, is a big issue. Oh, the pain's not that bad. And that's pretty common. And then, of course, attitude, personality, and experience. Generally that will be of the caregiver, and they're imposing their experience onto their loved one. But of course, it can be the patient themselves. So some physician factors: lack of knowledge of opioid or other analgesic usage, fear of the law. What are the side effects? They have misconceptions. So, patients or nurses may not be the only ones who think, are so concerned about, let's say, respiratory depression. That's like the first thing they're going to go for when you mention an opioid. Then hospice versus non-hospice. So I've heard physicians say they'll only prescribe opioids to their hospice patients. Not a lot of people are on hospice. That's a big problem. And then, of course, the physician's attitude, personality, and experience, personal experience in their training, their experience with their families and loved ones. Other factors, other practitioners. Some community-dwelling elders have geriatric case managers who are non-medically trained and often social workers, and they may have their own misconceptions about pain medications and discomforts. Nurses, nurse practitioners, sometimes you may have heard nurses say, well, you write an order for something or put it in, I guess, PRISM, and they're not going to give it. They know what happens. And that's also very common in nursing homes, that happens. Of course, concern about side effects. And then fear of the law. The law is all around us. On TV, we hear the commercials for law firms, ads for them. Will you prescribe such and such? Who knows what medication will be next on that list. And then, of course, the attitude, personality, and experience. So what's wrong? Cost to society, emergency department visits. What is the cost of an elderly person in pain? To themselves. There are huge numbers of older adults in pain. Studies really vary. It can be up to 85%, and that can be in cancer pain and non-cancer pain. It can be in the community and in nursing facilities. I mentioned that. Okay. And then mixed messages that we get. So in nursing facilities, they have something called an MDS, minimum data set. And one of the indicators on there is pain. So, all right, they have to look for pain, they have to evaluate pain, they have to record what that nursing home resident's pain is, and yet at the same time, they're always concerned about actually treating the pain and what are going to be the side effects and, some of the things that we've already mentioned. So why is treating pain of benefit? Pain is the fifth vital sign. It's really important. It's that important that it's been designated to be a vital sign. Of course, the importance to individuals and importance to society. Now we're going to look at some of the pharmacokinetics and aging, because there are definitely some effects that occur as we get older in the absorption, distribution, metabolism, and elimination of medications. So the rate of absorption of a medication may be slowed, but the extent is usually unchanged as we get older. If you think about somebody who's using, let's say, a fentanyl patch or a lidoderm patch, and they have very frail skin. All of us have seen elderly people, especially frail, chronically ill elderly people, and they have very frail, friable skin. So what does that do to a medication that's supposed to be absorbed transdermally, be it in a patch or a gel formulation? So splanchnic blood flow is reduced, leading to an increased bioavailability of medications which undergo extensive first-pass metabolism. Normally, medications that undergo first-pass metabolism leads to a decrease in their bioavailability. That's why, for instance, when you're giving morphine orally, versus IV, you have to give a larger dose orally because of the first pass hepatic metabolism. And those are just some of the examples of the medications. So distribution, we look at water-soluble drugs, fat-soluble drugs, and then protein binding. So water-soluble drugs have a lower volume of distribution, and that's because as we age, we have less body water, and we have also a decrease in the lean body mass. So alcohol, lithium, aminoglycosides will have a lower volume of distribution. And therefore, lower doses are needed to obtain a therapeutic effect. And those are not the only ones, but those are just some examples. In fat-soluble drugs, as we age, we have an increase in the fat stores. That may be hard to see in somebody who comes in who's, this really frail, cachectic, elderly person. But even in that person, they have more body fat, at least internally, than they do total body water, which decreases, and also they have the decrease in lean body mass. So because there is an increase in the fat stores, it takes longer for lipophilic drugs to reach the steady state, and therefore longer for them to be eliminated. So these medications are examples of those. So as you'll see as we're going along, there just seems to be so many instances where we need to really look at the dosage that we're starting in an elderly person, and not necessarily go by the little pocket pharmacopoeia that we carry around, or that, the dose that has been ingrained in our head for a general adult population. Because the elderly, really, we need to start lower. Protein binding affects the volume of distribution. So in a healthy elderly person, it's very likely that they're going to have a normal serum albumin. But as they get older and as they get more frail or more chronically ill, the serum albumin will be lower. And therefore, there's less binding available and more free drug that's available. Again, leading to the need for lower dosages. Liver blood flow and liver size are decreased as well as we get older, often leading to a reduction in metabolic clearance of drugs. Now, of course, there are other cytochrome P450 enzymes, but what we know is that cytochrome P450 2D6 has minimal age-related changes. On the other hand, 3A4, there's a decrease in the amount after we turn 40, and then again after we turn 70. And of course, in our pharmacopoeia books, there are, vast pages of lists with medications and which medications are inhibited or metabolized or used as a substrate for these cytochrome P450 enzymes. Phase 1 and Phase 2 reactions are handled differently in the elderly. Phase 2 reactions are mostly unchanged in older patients. Phase 1 reactions, on the other hand, are reduced. And there are quite a few medications that we use that it's affected by that. And again, leading to needing lower dosages. Drug elimination. There is often a decrease in the renal mass and renal blood flow, leading to a decrease in glomerular filtration rate. And with a drop in the GFR, there's a drop in the excretion of water-soluble medications. So if you think about chronic dosing, that leads to increased serum concentration because of the decreased clearance and increased elimination half-time. Now, when we're calculating creatinine clearance, which is how we usually figure out how we need to reduce the medication in someone with renal insufficiency, if we're looking at an elderly person, the creatinine is not an accurate measure, even though it's what we need to use, because getting a 24-hour urine creatinine doesn't make any sense. So we look at it, but we need to also take that with a grain of salt. So the creatinine often will look, may look normal, may be in the normal range for the lab, but because of the decline in lean muscle mass that happens as we get older, there is a decreased production of creatinine. And because of the decrease in GFR, it counters that decrease in the creatinine production, and therefore the creatinine looks like it's staying in normal limits. So in summary, with the pharmacokinetics, the rate of absorption may be slowed. Often we use the serum creatinine as an indicator of renal function, but in the elderly, due to loss of muscle mass, this number may be undervalued. There's a decrease in intracellular water and an increase in body fat content, which influence the volume of distribution of medications. Metabolic clearance of drugs by the liver may be decreased because of decreased size and liver blood flow. And also, aging is highly individualized. Just the way mentioned about an 85-year-old who's spry and living on their own, and a 66-year-old who's bedbound in a nursing home with chronic illnesses, aging is highly individualized. So the best way to handle medications in an elderly person is to start low and go slow. And I'm sure most of you have heard of that, but then you also want to titrate upward and monitor. Adverse drug events, very common in the elderly. 5 to 28% of acute geriatric hospital admissions are for adverse drug events. Polypharmacy is a huge issue in the elderly. Risk factors for these adverse drug events include these items. So age greater than 85, a low body mass index, more than 6 chronic medical illnesses, an estimated creatinine clearance less than 50, someone being on more than 9 medications, and more than 12 doses of daily medications, and also a prior adverse drug reaction. This may or may not happen as much. I was going to say this may or may not happen as much in the community as it does in the nursing home, but it absolutely does happen in the community. Any of these risk factors, a red light should go off in your mind to just be on the lookout for an adverse drug event. So Beer's criteria. So Beer's criteria was originally developed in 1991. And it was a list of medications that were decided to be inappropriate for use in older nursing home residents. So people over the age of 65 in nursing homes. Then it was revised in 1997 and actually in 2002, but published in 2003. And it was updated to include those people over the age of 65 but living in the community. Of course, these are guidelines. If you work in a long-term care facility in a SNF, and also I'm sure in the hospitals as well, the pharmacies will, send you emails or notes of some sort saying, your patient or your resident is on this medication, consider changing it to something else because, it's been shown to have a lot of adverse effects. So these, this can be used sort of against us as physicians, but also something to just keep in mind. These are guidelines, and we do know our patients, and because we need to individualize everything, again, we need to individualize our use of these quote-unquote risky medications in our older population. Oh, this didn't come out. Okay. This slide was supposed to just show the updates from the original Beer's list to the later versions of the Beer's lists. And just showing medications that were added, that were subtracted. I mean, it's quite an extensive list if you actually look at the whole list online. There also, in this list, includes chronic conditions and medications that should be avoided in patients in patients having those chronic conditions. So it's not just a list of medications themselves. So then we're going to move on. Types of pain. You're all very well aware of these, so I'm not going to describe this, but you can see the slide. Just to say, in the elderly, we ask our patients for pain descriptors, but very often in the elderly, they can't do it. They can't tell us what kind of pain they're having. They can't describe it to us. And that's even in cognitively intact patients. So just keep that in mind. It's not that you don't want to ask, but just know that if they're not answering those questions, it's not because they're trying to be difficult. It's just their perception of it is a little different and they can't quite describe it, which of course makes it more difficult when we're trying to target therapy. So how do we know someone is in pain? Self-report. I mean, that's the gold standard. We ask people. If they're cognitively intact, we can do that. They may not be able to say where the pain is. They may not be able to describe it to us, but they're saying they're in pain, so we have to sort of go with that. Then a physical exam, of course, will help us. Moving their limbs around to see if it's, musculoskeletal. Did they fracture something? Do they have something worse going on internally? Do they have peritonitis, for instance? Numeric scales, the traditional 0 to 10. Word descriptions, visual analog scales, the Wong-Baker FACES scale. So not just for pediatric patients, but we can also use that in cognitively intact patients. And then how does it interfere with their sleep, with their activities of daily living, and with their mood? Much more tricky in the cognitively impaired patient. There are scales. The FLAC is only one of them, and I'm going to talk about that in the next slide. Visual cues, and then information from known caregivers. Even in the cognitively impaired, if they're verbal, we should still ask them if they're having pain. So the FLAC scale. So FLAC stands for face, legs, crying, activity, and consolability. It's a 0 to 10 scale, like the numeric pain scale. And each of these can have 2 points a maximum, for a maximum of 10. So again, 10 would be the worst, 0 would be no pain. And instead of verbally asking them, we're using cues. So what are some limits to pain assessment in cognitively limited elderly people? So consider what else a crying, moaning, non-consolable person may feel. Maybe their foot is caught in a bed rail. Maybe they're scared. I mean, there are just so many things. Maybe they're hungry. Maybe maybe if they're in a facility or not in a facility and they're wearing diapers, maybe they're wet. Maybe they're soiled. I mean, it could be just so many things. And who is best to judge? I mean, there have been studies on this, and so far what's been found is, at least in nursing facilities, is that a trained, certified nursing assistant who has been trained to know what to look for and knows that particular resident, so ideally continuity of care, they are the best to judge. So it's not the family who comes in once a week. We have to listen to them, but it's really going to be more the professionals who have the hands-on care who are going to be the best to know. Of course, in a facility, you want to talk to the nursing staff as well as the CNAs. So never blow off the caregivers. So let's treat the pain. So there's definitely a role of an interdisciplinary team. We have it in hospitals. We have that in nursing facilities, assisted living facilities, sometimes in communities, depending on what the situation is. Then the traditional things, non-pharmacologic methods, non-opioid analgesics, opioids, and then some adjuvant analgesics. So the non-pharmacologic methods everyone is familiar with: heat and cold, massage, exercise if they can do it, visual imagery, and acupuncture. So again, this is going to be, based somewhat on your experience, on the patient's experience, the caregiver's experience, acupuncture in particular, what are their beliefs about it? Have they had it before? Did they know someone who, had it in the past and it worked great, or it didn't work? Non-opioid analgesics. So Tylenol, everybody just sort of, oh, Tylenol, just sort of blows it off. It actually can be an effective medication in the right circumstance with an elderly patient. They talk about the 4-gram maximum in a 24-hour period. In the elderly, ideally, you want to aim for 2 to 3 grams maximum in a 24-hour period. Non-steroidals, oral non-steroidals, diclofenac actually has a topical gel. And then topical agents can be effective in the right setting and with the right patient. So let's talk about NSAIDs. They're really common. What are their benefits? So they're relatively inexpensive. They're very easily accessible. There are a variety of brands, and there's no societal stigma. So most people, I would say, don't have a lot of negative connotation to nonsteroidals. Of course, unless they have a loved one, who had a GI bleed and died. Besides, something extreme like that, they're not going to have a lot of societal stigma. So what are the risks? Well, there are actually a lot of risks. A lot of the nonsteroidals are highly protein bound. And if you have a frail elderly person who has a low serum albumin, that leaves a lot of free nonsteroidal anti-inflammatory roaming around in their blood, which can lead to toxicity. And then some of the specific effects. So the GI effects, so they can have dyspepsia, peptic ulcers, bleeding, hepatotoxicity, and of course this is worse when they're taking systemic corticosteroids or warfarin. Risk is increased in the first 30 days, and then of course continues for the time of the use of the NSAID. Limited studies had shown that celecoxib decreased the risk of GI bleeding, but all of the nonsteroidals, including the COX-2 inhibitors, have black box warnings for GI bleeding. Well, GI side effects. Renal effects. So both non-selective and the COX-2 selective inhibitors affect the renal system. There's a decrease in glomerular perfusion, filtration, and they can lead to acute renal failure. And that could be any time in the course of therapy. So you start them off, you may start them off low, you may start them off slowly, you may increase a little bit. They're on it for the first 2 months, nothing has happened. And maybe 8 months, a year and a half out, something major happens. There is an increased risk in the elderly who have pre-existing chronic kidney disease. That makes sense. So you want to monitor their electrolytes. And also with nonsteroidals that have long half-lives, or longer half-lives, they're more of a risk. Cerebrovascular and cardiovascular effects. So this is really because of the prostaglandins. As we know, nonsteroidals decrease the conversion of arachidonic acid to prostaglandin by inhibiting cyclooxygenase. So if the prostaglandins and thromboxane are inhibited, that can affect all of this, particularly the renal and cerebrovascular and cardiovascular. So there are black box warnings for cardiovascular and cerebrovascular effects, including MI and stroke. They're looking at people who take cardioprotective aspirin. because of the antiplatelet effect of low-dose aspirin and the inhibition of the production of thromboxane, there is an interference there, and it inhibits the protective effect of aspirin. So if you do have to use a nonsteroidal on somebody who's taking low-dose aspirin, you want to give the aspirin 2 hours before the nonsteroidal. If you're giving it after the nonsteroidal, then you're inhibiting the effect, again, because of the prostaglandin, and that's a more long-acting effect than the antiplatelet effect of the cardioprotective aspirin. Hypertension may be exacerbated. CHF can actually be worsened, or it can cause CHF because of systemic vasoconstriction. And the systemic vasoconstriction can interfere with ACE inhibitors and ARBs, their afterload reduction, as well as the diuretic response. And actually, the American Geriatric Society recommends avoiding aspirin and ibuprofen. They say that specifically, but black box warnings are written for all of them. CNS effects. There's confusion, cognitive dysfunction, and even aseptic meningitis. Indomethacin, it has said, causes more CNS effects than other NSAIDs in the elderly. So again, with the NSAIDs, if you need to use them, you want to use the lowest effective dose. You want to use it for the shortest amount of time that you can, and use the one that has the longest, the shortest, not the longest, the shortest half-life. And this slide is just showing when you go from arachidonic acid to the prostaglandins. So on the right, the cyclooxygenase, the nonsteroidal anti-inflammatories inhibit that. Above that, the phospholipids. The phospholipase A2 is inhibited by steroids. So they both have a similar mechanism of action in that they inhibit prostaglandin synthesis. And that's why you don't usually have someone on a corticosteroid and a nonsteroidal anti-inflammatory. So this is just reiterating some of that, the effects of the nonsteroidal anti-inflammatories. So if someone has volume depletion, that makes it worse. The risk of the side effects are even worse. And it can be true volume depletion or volume depletion related to heart failure or cirrhosis. And then this slide is just showing the reduction in the GFR in patients who took indomethacin or ibuprofen. So it's pretty dramatic. So turning to opioids. So the usual agents that everyone knows about, the combination agents. Mode of administration, need to consider that in the elderly. You know, can they swallow, or how good is their swallowing, I should say. Doesn't have to be so extreme, but how good is their swallowing? And then the side effects. The adjuvant analgesics. Neuropathic pain in the elderly. So definitions that people are familiar with: allodynia, pain from stimuli that are not normally painful; hyperalgesia, an increased response to a painful stimuli. So these are medications that are often used to treat neuropathic pain in anyone, not just the elderly. The TCAs are the ones that are studied the best, the tricyclic antidepressants. The SNRIs, like venlafaxine, also can be very effective. The tricyclic antidepressants, it has been shown that the number needed to treat, which is often what we look at, is approximately 3. Venlafaxine, the SNRI, also has a number needed to treat about 3. So in terms of efficacy for treating neuropathic pain, you know, they're very similar. But we'll see why TCAs are not so great in the elderly. So anticonvulsants, You know, starting doses, typically in the elderly, you want to start on the lower side, on the right-hand side, just some of the side effects of each of them. So gabapentin and pregabalin, you want to renally adjust the dose. So you're adjusting because you're starting low because they're elderly, and then you may even want to adjust it even further because based on the calculated creatinine clearance, but you know that that creatinine is not really exactly reflective of what their creatinine clearance is when you calculate it out. So you may be even starting with lower doses. The antidepressants, the tricyclic antidepressants, and the SNRIs, again, low doses. Venlafaxine also comes in a sustained release formulation. I would never start some elderly person on an extended release venlafaxine without at least trying the regular acting and seeing how they respond to it. So some drug interactions, drug-drug interactions. So we were saying about the tricyclic antidepressants, you know, everybody's aware of the anticholinergic side effects, the hot, red, dry, and mad, you know, the urinary retention. Those can be even exacerbated in the elderly. So then you think, okay, well, what about the SNRIs? Well, the SNRI is great, but there are definitely some cytochrome P450 drug interactions that you have to think about. How many elderly people are on amiodarone or Haldol? I mean, so it's just things to keep in mind. And then also with duloxetine. So the NMDA receptor antagonists, ketamine and methadone, can be very effective in the right patient. You know, of course, starting low, going slow, titrating, and monitoring. So some challenges, you know, mentioned about the mode of administration. So if they can swallow, that's great. That's the best way. You know, obviously if they're outpatient. Maybe they need gels if they can't swallow. Are they on hospice? Are they not on hospice? Are they in the community? Are they in a skilled nursing facility? That's also going to limit, if they're in a skilled nursing facility, that's going to limit what medications that we can get, what medications can be compounded, because we have to deal with the nursing facility's pharmacy. Hospice versus non-hospice. In hospice, you know, we have great things like an ABHR suppository, Ativan, Benadryl, Haldol, Reglan suppository, you know, an all-in-one. That's a hospice special. But, you know, how many other patients are going to be able to get access to that? Maybe some, but that might be hard to find. And then what are the costs to individuals and the cost to society? You know what, I just want to go back for a minute. So the cost to individuals and cost to society. You know, we've always looked at, or I've always heard, you know, you look at countries' infant mortality rates, you know, and as an indicator of how their society is taking care of their citizens. I mean, I'd like to say that the amount of treatment that we give to our patients with pain, not just the elderly, but everyone, can also be an indicator of how we take care of our patients and an indicator of what our society is like. So this slide actually has a lot in it, but what we're concerned about just in this is the prescription drugs, the purple, going from 8 to 16%. So that is the percentage of cost of Medicare, of prescription drugs for Medicare enrollees age 65 and older. From 1992 in this first box to 2006 here. So, and you know the numbers are higher now in 2011. So in summary, so with adult medicine, you can't avoid treating the elderly. So you need to try and keep in mind various things that we talked about. Pain is not an inevitable part of aging, but it will increase, likely increase as we get older. Consider how you know that someone has pain. Review their medications regularly. Often, elderly patients go to various prescribers. They have pain, they go to one doc. One doc gives them one thing, they go to another doc because the pain's not controlled. They may or may not be compliant with their medication, so they go to another one and another one. So it's good to review their medications regularly. With the elderly, often the therapy is focused on what to avoid as opposed to what medications to treat with. So looking at the side effects and the falls and the polypharmacy in the elderly. Start low, go slow, but continue to titrate and monitor. And then how to monitor for them for therapeutic effect. It's going to be the same kind of thing, in terms of assessing them for pain. And remember, that will be us someday. So hopefully we'll do a good job with them. And then hopefully we can all just be happy and social. Thank you.